Hello and welcome to the slides on acute pyelonephritis. Pyelonephritis is fairly common in the United States with over 200,000 cases reported per year. It does require lab tests, imaging to diagnose, and can last several days to a couple weeks, and it needs to be treated by antibiotics. The etiology of pyelonephritis is that it's an inflammation of that renal parenchyma and the collecting system. The most common cause is a bacterial infection, including E. coli, but fungi, protozoa, and viruses may also be a causative organism. Sometimes the development of urosepsis occurs, and that's a systemic infection coming from a urological source like a UTI or pyelonephritis. Urosepsis is an emergency that can lead to septic shock and death and needs to be quickly identified and treated for good outcomes. Here is an awesome picture of pyelonephritis, shows how icky and gross it is, but we can see the areas of inflammation and the abscess formation, which is what those arrows are pointing at, with a very fulminant, overwhelming pyelonephritis. The pyelonephritis usually begins with the colonization and infection of the lower tract, and it follows an ascending route. So what this means is that usually a patient will have bacteria colonizing in the bladder, or in the urethra, and it kind of grows up and goes into the ureters, getting up into the kidneys, and there again it will colonize and flourish and cause a kidney infection. One of the most important risk factors for an acute pyelonephritis is the pregnancy-induced physiological changes in the urinary system. And so this can include dysfunction of the lower urinary tract, like the change in pH. In men, the dysfunction of the urinary tract, including benign prostatic hypertrophy or obstruction from stones, can cause that urinary stasis and then that ascending type infection. For residents of long-term care, the catheter-associated UTI is a common cause of pyelonephritis and urosepsis. So again, pyelonephritis is caused due to urinary tract infection by the pathogens such as bacteria, and we can see the different ones there, mainly E. coli. It starts in the urinary tract and then spreads to the kidneys. The bacteria then enters the body through the urethral opening, and then it multiplies and spreads upwards into the kidneys to cause an infection. So the different organisms are there, but there can be a time when a bloodstream infection can spread to the kidneys and cause pyelonephritis, but that is pretty rare. It usually is an ascending route infection. Clinical manifestations of acute pyelonephritis can vary from mild fatigue to sudden onset of chills, fever, malaise, vomiting, flank pain, and the lower urinary tract symptoms characteristics of bladder inflammation or cystitis. And those LUTS signs and symptoms are hesitancy, urgency, feeling like, frequent trips to the bathroom and not emptying right, pain with urination. So those LUTs, again, are characteristic of the not emptying of the bladder or a problem with the storage of the urine in the bladder. The costovertebral tenderness can be assessed by percussing that CVA angle. And so it is on your back, and it is right below where our rib cage ends. And so you take the heel kind of your hand, press it, you take your fist, put it into that CVA angle, and then you would take the heel of your hand and kind of bump on that spot. And usually the person is going to flinch or really be, oh God, that hurts. And they're really going to pull away and be mad. So it is only painful on that affected side of the pyelonephritis. Other symptoms include cloudy urine, pus or blood in the urine, fishy smelling urine, and then again fever and nausea are pretty common with pyelonephritis. So how we assess patients, we need a combination of subjective and objective data, and these are outlined on table 45.5, and that is on page 1037 in your text. But first we want to look at a health history. So do they have previous urinary tract infections or other issues with the urinary system that could lead to pyelonephritis, like calculi, kidney stones, urinary stones? Do they take antibiotics? Do they have recent instrumentation or Foley catheter use? We can assess, how are they performing hygiene? Are they wiping from front to back, especially in women, to make sure we're clearing that, E. coli from the urethral area? What kind of pain are they having? Where is the pain? When does it happen? So all of those things are coming from our health history. Objectively, again, we see things like fever. That's very, very common in pyelonephritis. Foul, smelling, cloudy urine. The tenderness at that CVA angle. And then when we get a urine sample and we're looking at it, we can see positive findings for bacteria in the urine, such as those nitrates, positive leukocyte estrates, WBCs in the urine. And so all of those will give us a clue that there is an issue in the urinary tract. And lastly, objective data we can look at for CT scan for inflammation in the kidney, and look at our CBC and see elevated white blood cells. So to help diagnose, we're going to do the urinalysis. Okay. We'll want to reflex that back for culture and sensitivity to make sure that we're getting on the right antibiotics and that there's no bacterial resistance there. Looking again at the CBC with a white blood cell count, looking at differential to see acute infection. The CBC will show us again that leukocytosis, which is an increase in WBCs, and the shift to the left. So that is telling us that, again, an acute infection. So looking at the bands on that CBC with differential. Sometimes when the patient is severe and hospitalized for pyelonephritis, we may do blood cultures depending on how they're presenting. And again, that would be if we're suspecting urosepsis coming from the pyelonephritis, we would see if it has gone system-wide. Interprofessional care includes up to hospitalization, and this is again for patients with severe infections or they have nausea, vomiting, and signs of dehydration. The patient with mild symptoms may be treated as an outpatient, and the antibiotic treatment is pretty lengthy for pyelonephritis, anywhere from 14 to 21 days. When that initial treatment does resolve those acute symptoms and the patient is able to tolerate food and drugs, the patient is discharged from the hospital on an oral regimen. So initially when they're in the hospital, we're going to do IV antibiotics because they hit the bloodstream right away and don't have that first pass metabolism. And then when they, again, are feeling better after a few days in the hospital with IV fluids, then they will go home on an oral antibiotic. We can give NSAIDs, and that's going to be for that discomfort that they are feeling. We can do antipyretics or ibuprofen for fever that they're having, as well as urinary analgesics like the ones that we looked at for the UTI, like the phenylpyridine, which is going to color their urine, so we want to make sure that they know that. Sometimes pyelonephritis can have relapses, and if that does occur, they're going to be on a long-term 6-week course of antibiotics, and we definitely are going to do follow-up urine culture and CT scan to make sure that we are resolving. Otherwise, the kidney can get scarred, and then we can have sequelae of kidney injury. Urosepsis is characterized by both infection in the urine that we can see on our urinalysis and infection in the bloodstream, which we'll see with those blood cultures. So if urosepsis again is present or suspected and we confirm it with the blood cultures, we are going to keep them in the hospital, have close observation for those signs of septic shock. After we've identified the acute pyelonephritis and we are sending the patient home, we want to make sure that they are going to follow the regimen and take those antibiotics or other medications as prescribed. We want to make sure they come back in to have a follow-up urine culture done, and again, we just want to make sure that it is resolving so that we don't have further complications of the pyelonephritis. Encouraging them to intake adequate fluids, to get their rest, and that's all part of the healing process of having an acute infection. Our nursing interventions really are going to vary depending on the severity of the symptoms. But rest, fluids, taking the antibiotics, those are all the mainstays of treatment for a patient who is having an infection of the kidney. And lastly, our evaluation of a patient with acute pyelonephritis is if they are, taking the antibiotics and we're identifying the source and the reason and treating it. What outcomes will we have? Well, we will have urine free of blood. We will have the patient adequately intaking fluids, passing urine without those lower urinary tract symptoms like urgency, hesitancy, frequency, appropriate use of analgesics for pain, and also the use of non-analgesic relief measures, which might be heat to the flank to kind of relieve some pain. Thank you so much.